I got my notes here so I can keep to the 7 minutes. But good morning, everyone. It's great to be here with so many of our colleagues and learn about all of the great work that's happening. I'll be going at lightning speed for the lightning talk, so just stay with me. I have the privilege of serving as director of one of our research centers at the School of Public Health, Center for Health Equity. I'm a behavioral epidemiologist by training, and one of my areas of research is largely around design, implementation, evaluation of behavioral interventions to improve health. And what's interesting is that the area that I've primarily focused on from a behavior standpoint, which is actually a non-medical driver of health, is food insecurity and healthy eating. However, in doing this work of behavioral interventions with schools, clinics, community organizations, communities themselves, one of the persistent issues that we have encountered, regardless of which system organization that we're partnering with, is one of care coordination. And this persistent issue is part of the solution itself that we're trying to offer. So that's what I'm going to talk about today, because without care coordination, largely a lot of the work that we do from an intervention standpoint remains lacking. So I think, let me see if I can. So the best way to really learn about care coordination is how does it show up for our patients. So I'm going to share with you some of the data that we've collected qualitatively, specifically to understand care coordination issues. So here's a quote from a 62-year-old patient. The thing of it is, yeah, I didn't have nobody to take me because everybody was working. But before then, I was driving myself. But since I had COVID, I'm still having shortness of breath. So I have to wait till I can get somebody to take me. Help is given to someone when they need it. And if I didn't get it, perhaps it's because I didn't need it. This patient perceived that they didn't get the help because someone thought they didn't need it. I mean, honestly, there's times that we all struggle at some point, right? And we just want to have something to rely on when it comes to our health. So you might wonder, who are these patients? Well, these are all patients, adult patients with type 2 diabetes, who have been enrolled in a clinic-integrated produce prescription program. So they're already enrolled, but they never received the service. So let's zoom out for a minute on what this problem looks like in regards to care coordination. So this is a fact that we're all very familiar with. We are a region of high need, lots of health disparities, and lots of needs in regards to non-medical drivers of health, right? Access to food, access to healthcare, housing, transportation. But we're also a region where many of our organizations have invested heavily, actually, in regards to addressing these needs, right? If you're using Epic, you have the social determinants of health wheel, you're screening your patients, and then you're sending them somewhere, right? Because we are certainly not growing food. Well, some of us are at the School of Public Health, but we're not growing enough food to feed our patients when they're food insecure. So we have to refer them to somewhere. And that's the part of care coordination that's missing. The challenge is that patients and clients are not getting the services they need, even though these services have been proven to be evidence-based in the sense when you provide the services, it improves health outcomes. And the reason for that is there's this gap of warm referral and what we call closing of the loop between healthcare and social services organizations for non-medical drivers of health, because you have a HIPAA-covered entity that is unable to share data with non-HIPAA-covered entities like community-based organizations that are actually meeting providing the service. So how does this show up for our patients? Let me give you an example, and I'm going to focus on food because that's what I spend a lot of my time on. So here we have our health systems doing a wonderful job on screening for non-medical drivers of health, right? So we have 4 patients here who you think are food insecure, have a diet-related chronic condition. You want to enroll them in a produce prescription program. And you do, and you send them to the food pharmacy. So maybe this is a produce prescription program that's offered by a community-based organization that has a food pantry, does even home delivery. Well, out of the 4, only 1 patient ends up receiving the actual program. And the reason you would ask is why, right? This is a patient who needs this to manage their medical condition, which is why you want them enrolled. And the reasons for those are articulated there below. It's because the referral is entirely unidirectional. Sometimes it can be a paper prescription, in the sense that the patient gets, oh, here you go find go to the food bank. There's no warm referral. And largely, one of the studies we did, which is the largest evaluation of a food bank-based produce prescription program, is that there was a clinically meaningful change and statistically significant change in hemoglobin A1C among those who participated in the program, but only 50% of those enrolled actually received the program itself, right? So if the services are not implemented or accessed as planned, then how can we assess the impact and attribute the changes in the outcome to the service delivered? So this is the core work or the question that we've been trying to address, which is that of building closed loop referral, having a no wrong door approach for our patients, and really inverting the burden when it comes to receiving these services, because right now it's not working. And so that's some of the work we're doing. This is our framework of the Center for Health Equity. We operate in a 3-layer cake. The very bottom layer is the layer of infrastructure, which is really all of this care coordination infrastructure that perhaps is lacking in the space of non-medical drivers of health. And then you have the layer of, you need to have data insights, right? And when you have these core infrastructures in place, whether it's data or care coordination, then your interventions can sustain and succeed, right? And so that's the ethos within which a lot of our work is grounded. And the coalition, so we have a very large systems coalition called the Health Equity Collective that is really driving this work of care coordination. So what is the Health Equity Collective? And I invite you to learn more, happy to chat more after, but it's a multi-sector, action-oriented, collective impact effort to improve care coordination for non-medical drivers of health. It's 6 years old. This is not research, but it's core infrastructure where we are bringing systems together. So we have over 325 healthcare, community, and academic institutions coming together, over 50 coalitions in the greater Houston region to specifically work on care coordination for non-medical drivers of health. Heidi McPherson and I have the privilege of co-leading this Health Equity Collective because we as an institution are the backbone organization for this collective. This is the structure. We have a lot of work going on with a lot of institutions, but the core of this work is that we have common agenda and shared metrics that are developed in this space. And one of the core areas is the closed loop referral work that we're doing. Sorry, this got cut off, but we have a lot of institutions that are on the steering committee across our region that participate very closely. So you'll ask me, well, what does good care coordination look like? So I'm going to share with you something that we all experience ubiquitously on what does seamless care look like in this space of healthcare. We all experience this. You go to the doctor, you have diabetes, the doctor says, take a medication. I want you to take metformin. Well, then magically the metformin appears at a pharmacy of your choice, right? That is done through a technology-based software called SureScripts. And it goes to the pharmacy, and it even shows up on your phone as a text reminder, does it not? That your prescription is ready for pickup. So there's a technology that's enabling this. And 15 years ago, only 4 out of 10 prescriptions were actually being filled. And it was due to this technology based and a policy support of reporting on opioid use that enabled this technology to be ramped up, where over 90% of health systems in the country use SureScripts ubiquitously to make these prescriptions. So we do live in a world where there is, and you can choose the Walgreens that you wanted to go to, can you not? There's also money to be made, right? There has to be a value proposition. There's billing on both sides, which sustains this work. And most of all, it closes the loop. You as a provider knows if your patient has received and picked this prescription from the pharmacy. This is the work that we're trying to replicate in the space of non-medical drivers of health. We have a very curated demonstration project going on at the moment where we are partnering with Health Connect Texas. That's our health information exchange. It's our local HIE. It has a master patient index of over 24 million at the moment. And most of our health systems right now pay to play in the HIE. So we're working with Herman, Legacy, San Jose Clinic to really see if we can leverage this technology and build out this closed loop referral between healthcare and social services for closing the loop on non-medical drivers of health, and do it in a way where there's sight lines on both sides, whether the referral has been met. We are going live next month. So I know, it's very exciting. It's also very unnerving. But we're also, one of the big questions, well, does it work, right? Just because you have a technology doesn't mean it's going to be used. And so we are answering questions. Michaela Sandoval, who is a faculty at the school, has built out a relational database for us to really look at, are we both being efficient and are we being effective? And so those are the questions we'll be looking at: hospitalizations, ED visits across these institutions, and also a whole host of other implementation outcomes. Maria, you'll be proud. And we're very excited to continue and amplify and build upon this work. So if you want to learn more, I want to end on this. It's not always about collecting data. Sometimes it's about connecting it. Feel free to reach out to us. We're happy to share more as well. Thank you.